Today, let's clear the confusion between the apexogenesis and apexification. So, what is apexogenesis? It's a vital pulp therapy. It is done to maintain the pulp vitality and allow the continued root development in immature teeth with open apices. So, it is indicated when the pulp is vital and the inflammation is limited to the coronal pulp. There is no history of pain, that is, there is no sign of irreversible pulpitis, no tender on percussion, and the bleeding from the pulp stumps can be easily controlled. And there is no radiographic evidence of the periapical pathology. Procedure for apexogenesis: the LA is administered, rubber dam isolation is done. If there is any carious tooth structure, it is removed. Then the coronal pulp is removed with the help of a spoon excavator. The bleeding is controlled with the moist cotton pallet. Once the bleeding is stopped, the MTA or the calcium hydroxide is placed over the root stump and the temporary restoration is given. The regular follow-ups are must to monitor the healing. Key points to remember for apexogenesis: it's a vital pulp therapy. The radicular pulp must be healthy to do apexogenesis. It's a partial pulpotomy with materials like calcium hydroxide or MTA to maintain the pulp vitality. It's a physiological process of inducing the normal root development in an inflamed or infected vital tooth. It results in continued root formation, thicker root dentine, and a closed apex, reducing the fracture risk. The regular follow ups are essential to monitor the healing and the success of the treatment. So, it's a vital pulp therapy. This is something very important. It's a vital pulp therapy. Let's discuss apexification. It's a method to induce a calcific barrier across an open apex of an immature pulpless tooth. So it is done in a non-vital tooth with open apices. So it is indicated when the pulp is non-vital or irreversibly inflamed, when there is a history of trauma, infection, or necrotic pulp due to untreated caries, and when there are the radiographic evidences of periapical pathology. The apexification is indicated. Procedure of apexification: after administering local anesthesia and rubber dam isolation, the excess opening is done. The working length should be at least 2 mm short of the radiographic apex. The circumferential enlargement is effected by the lateral pressure against the walls with a larger file. After drying the canal, the entire root canal is filled with calcium hydroxide, ensuring that the material is in contact with the periapical tissues. Once the calcific barrier is formed, the obturation is done and the permanent restoration is given. Key points to remember: it's a non vital therapy. It involves the canal debridement and disinfection, which is followed by the placement of calcium hydroxide or MTA. It results in apical barrier formation, but it doesn't promote the root elongation and root remains thin and fragile. The regular follow ups are essential to monitor the healing and the success of the treatment. I hope this clears the confusion between apexogenesis and apexification.